Hello and welcome to this lesson, hiatal hernia. So, hiatal hernia is defined as herniation of stomach through the esophageal hiatus to the posterior mediastinum. So, if you look at a transverse section of junction between abdominal cavity and thoracic cavity, you can see that at the level of diaphragm, we have an opening which is called esophageal hiatus, and this is where in normal situation esophagus passes from thoracic cavity to the abdominal cavity and attaches itself to the stomach. In case of hiatal hernia, we have herniation of stomach through this opening, and the stomach actually is going to the posterior part of thoracic cavity. And we have few risk factors here. We can have obesity because it causes increase in intracranial pressure and weakening of esophageal hiatus. We can have aging. Due to aging, we have weakening of diaphragmatic muscles, and this helps for herniation of the stomach through the esophageal hiatus. And another risk factor is pregnancy, because in pregnancy again we have increase in intra-abdominal pressure and it weakens the esophageal hiatus muscles, which causes herniation of the stomach through the esophageal hiatus to the thoracic cavity. So what are the types of esophageal hernia? So we have four types. We have the first one, a sliding hiatal hernia, which is the most common form, and this is where we have gastroesophageal junction herniated through the esophageal hiatus above the diaphragm, and along with that we have some or all parts of the stomach herniated through the same opening up to the thoracic cavity. In the second part, we have herniation of gastric fundus into the mediastinum, and parallel with that we have esophagus running side by side of herniated gastric fundus. In this form, gastroesophageal junction stays inside the mediastinum, and in the third part, we have herniation of gastroesophageal junction and stomach into the mediastinum. And in the fourth type, we have herniation of stomach, gastroesophageal junction stays in the mediastinum, and other abdominal viscera like pancreas can also herniate to the thoracic cavity. So here we have demonstration of four types of hiatal hernia. Here in the first type, this is thoracic cavity and this is abdominal cavity. So in the first type, we have herniation of gastroesophageal junction above the diaphragm with some part of stomach. In the second type, we have herniation of gastric fundus, and this is parallel to the esophagus. In the third type, we have herniation of gastroesophageal junction along with stomach into the mediastinum, and in the fourth type, we have herniation of gastroesophageal junction and also the whole stomach, and along with that, we can have some other parts of abdominal viscera herniated through the esophageal hiatus. So what are the presentations of hiatal hernia? First of all, for most patients, because herniation is very small, the patients can be asymptomatic, and this is for majority of the cases. But if the symptoms appear in a patient, it is either due to mechanical pressures to the thoracic organs, for example lung, or it is due to long-standing gastroesophageal reflux disease. So what are the symptoms? Epigastric discomfort, especially after large meal. The patient can have chest pain, postprandial bloating, dysphagia due to long-standing GERD, or respiratory problems due to either aspiration or mechanical pressure. So the patient can have dyspnea, cough, aspiration pneumonia, or even asthma. And also because of the fact that we have compression and we have gastric mucosa erosion, the patient can have chronic blood loss from GI tract, which can be presented with anemia. So here we should define an ulcer, which is called Cameron ulcer. This is a mucosal fold ulceration of the stomach, and it is due to the fact that we have extrinsic compression of the diaphragm to the distal neck of hiatal hernia. This usually causes some ulceration, and in the long term they can bleed and cause GI bleeding, and anemia can be presentation. And here you can see three ulceration of Cameron ulcer. These are very mild ulcer that are not yet bleeding, but they can bleed and cause anemia in the patients who are suffering from hiatal hernia for a long time. So what are the diagnostic tools for diagnosis of hiatal hernia? The best tool that we have is barium swallow, and this is the best tool for diagnosis and typing of hiatal hernia. For example, in this picture, which is a barium swallow test, you can see gastroesophageal junction, and also you can see the sliding hernia of the stomach through the esophageal hiatus, and this is the diaphragm indicated in this test. Another test that we can use as a supplementary test is endoscopy, and this is done for ruling out the gastric cancer and esophageal cancer. Note that due to hiatal hernia, these patients are suffering from chronic esophageal and gastric inflammation, and this increases the risk of esophageal and gastric cancer. And also note that most of the patients who are suffering from hiatal hernia are over 60 or over 40, and this is also an increased risk for esophageal or gastric cancer. Another test that we can use for patients who are suffering from GERD secondary to hiatal hernia is esophageal manometry and pH monitoring of these patients, and this is usually done in order to assess the function of esophagus. Probably the best initial test for these patients is X-ray, and in the X-ray you can see air fluid level at the level of mediastinum. So here in this picture you can see an air fluid level at the mediastinum, and this is pathognomonic for hiatal hernia. This is fundus of the stomach, and this is empty, so it is filled with air, and below that you can see that there is an air level. So this is a pathognomonic demonstration of X-ray in patients who are suffering from hiatal hernia. So what are the complications and treatments for hiatal hernia? Of course, we can have hemorrhage, gastrointestinal hemorrhage is possible. We can have incarceration, and also we can have obstruction to the gastrointestinal tract, because again, remember, gastroesophageal function and stomach is passing through the esophageal hiatus, so we can have obstruction of these areas. Also, we can have strangulations, and bleeding from mucosal surface is also possible, leading to anemia in chronic phase. Obstruction is usually due to the fact that we have a stocking of gastroesophageal function to the diaphragm, and also gastric erosion is possible, as we see in Cameron ulcers. Now, what are the treatment options? Treatment options are reserved for symptomatic patients. So we do surgical repair of hiatal hernia. We put back herniated organs back into the abdominal cavity, and also in order to address the gastroesophageal reflux disease, the patient should undergo fundoplication in order to have treatment for GERD. And usually this is done with laparoscopic method because it has less post-operative complications, and healing rate is much better than open abdominal and thoracic surgeries. Thank you for watching.